All right, so this is the last of the renal section that we're going to do for the following the NCCPA blueprint for the pants. Um, so this will be the last video that we do, and just going over some of the chronic kidney disease, acid-base disorders, and a few other things related to electrolyte dysfunctions. So that being said, let's go ahead and get started. And I just want to remind you guys, I'm going to start making videos pretty much every week. So I would go ahead and subscribe. I'll have a lot more videos coming very soon. So the first thing that I want to get into is chronic kidney disease, which is pretty straightforward. There's not a lot to know here. I think a lot of people stress knowing the stage levels, stage 1, 2, 3, 4, 5 of of the actual kidney disease, and I don't think it's that important for you to learn. I don't remember ever being asked that in school, but we'll go over it and just go over some of those numbers. So chronic kidney disease is a progressive functional decline for 3 or more months, and then it's accompanied by something else going on with whether it's proteinuria, abnormal urine sediment, abnormal imaging studies like an ultrasound, something else besides that functional decline going on for 3 or more months. So these are the actual stages. Again, I wouldn't commit this to memory. You have too much to learn in PA school anyways. This isn't important. But stage 1, so you have a normal GFR, it's over 90, but you have something else going on, whether it's proteinuria, again, just like before, abnormal urinalysis. Stage 2 is 89 to 60. Stage 3, 59 to 30. Stage 4 is 29 to 15, and then stage 5, this is probably the only one I would say if you're going to remember anything, remember this one because less than 15 GFR indicates a need for dialysis. So these patients are going to have to be on hemodialysis. So that is important. So you might want to recognize that because if it's in a vignette, this patient has a 12 GFR. It might ask you something relating to dialysis. So I would say that a stage 5 of all of these is probably the only one that I would commit to memory, and that's less than 15 GFR. As far as the causes, the most common cause by far of chronic kidney disease is diabetes. So that's important to know. Second most common cause is hypertension, but definitely no diabetes, most common cause for chronic kidney disease, because that is really important. That'll definitely come up. As far as diagnosing, proteinuria is the best early predictor. So you can see it with a couple different tests. There's a 24-hour urine collection or a spot urine albumin creatinine ratio, and this is something that is done on diabetic patients just to see if it's at their early signs, so we can make sure that they get some of the different treatment options. But that's one of your best predictors, your early predictors of chronic kidney disease is proteinuria. And some other things you can see is the waxy cast you can see on the urinalysis. And then in a renal ultrasound, the classic finding of chronic kidney disease is small kidneys. But then they also say that in diabetic patients, the kidneys are enlarged. So I wouldn't really focus too much on that. But if you're going to remember anything, it's definitely the proteinuria. So remember that as an early predictor with the 24-hour urine collection or the albumin creatinine ratio. Treatment. So treatment is not, there's nothing really specific. There's not like one medication you give. It's pretty much treating everything in the body going on to prevent progression. And most of the time, there's nothing you can do to completely halt the progression, but we're trying to treat all of the other things going on to slow the progression, really. So you want to treat their hypertension. You want to maintain a blood pressure less than 140/90. ACEs and ARBs are huge. And they prevent the degradation of the kidney or slow the kidney disease seen in a lot of patients, and diabetic patients in particular. So these patients should definitely be on an ACE or an ARB, a lisinopril, losartan, whatever it is. You want to keep their A1C less than 7. These are diabetic patients. You want to keep their blood sugars in control. And then, of course, at stage 5, they're going to have to be on dialysis. So next thing in the blueprint. So Wilms tumor, also known as nephroblastoma. This is most commonly seen in children. So it's most commonly seen in the first 5 years of life. If you have a vignette, you're not going to see an adult. If it's going to be a kid, almost definitely, because this is almost always seen in young children less than 5 years. So this is how I remember some of the common things that you're going to see with a Wilms tumor. This is something that I came up with that I think really helps. And if you kind of know this, there's not too much else to really know. These are the main things that they're gonna ask you about that I remember seeing when I was in school. Questions about this. So I have this mnemonic that I remember. So Wilms First one obviously stands for Wilms tumor. Second thing is iris malformation. They have something called aniridia, and it's actually an absence of the iris. If you look it up on Google, it's pretty interesting, but there's no iris. And this is something that children with a Wilms tumor can have. Most of the time, it's actually in both eyes. The other thing, the L is locked in position of tumor. So the tumor doesn't cross the midline of the abdomen, which differentiates it from neuroblastoma of the adrenals, which actually does cross the midline. So this is important because this is another thing to help you differentiate on vignette. So locked in position of the tumor, not crossing the midline. Mental retardation is also seen in patients with Wilms tumor. And then finally, sexual malformation, things like hypospadias, cryptorchidism are also seen in these patients. So remember this, and there's really, I feel like you'll probably get the question right if you can just remember these 5 things. So as far as the other parts of the presentation, is again, I already went over this, the abdominal mass, it doesn't cross the midline. They may also have hematuria, constipation. Diagnosis, you're going to do an ultrasound. And then as far as treatment, total nephrectomy with chemo, 80-90% cure rate. So this is something that's pretty treatable. Renal cell carcinoma. So it's a tumor of the proximal convoluted renal tubule cells. This area has a high metabolic rate, so it's really susceptible or prone to dysplasia. So that's important to know because of the area that it's in. That's why this area is so common for carcinoma. And 95% of tumors in the kidney are actually of this type. And the most common is clear cell. Some of the risks, just like in a lot of cancer, smoking, hypertension, obesity, patients on dialysis, and men are more prone to renal cell carcinomas. So the triad is important. This is something that I remember seeing in school, and this is kind of important. So you're going to see a triad of hematuria. You're going to have blood in the urine. They're going to have flank or abdominal pain and a palpable abdominal mass. So that one I think is pretty important to know. They also may present, and this is interesting, with a left-sided varicocele. So if it does metastasize, the most common area for it to metastasize is to the lungs. And this is really important to remember because you may have a patient presenting with hypercalcemia, and that may be the only finding that you see. And in real life and on exams, it's important that you consider the potential of malignancy, like renal cell carcinoma in particular, because this tumor, it's not the only one that does this, but this tumor does actually secrete PTHRP, which is parathyroid hormone related protein, and it can mimic primary hyperparathyroid, which bumps up the calcium in the body. So if you have a patient presenting with hypercalcemia, this is an important diagnosis to consider, and also you may see this on the vignette. So this is also another thing, an important thing to remember. So you're going to diagnose this with a CT, and then treatment is just going to be a radical nephrectomy. So these aren't really too important to know, but I think some of the more important things I've underlined here and put in bold, things that I think you should remember for the exam. Okay, so acid-base disorders. I'm going to do my best to go over this. Again, this is something that I feel like a lot of people commit a lot of time to learning, and I don't think it's super important. I don't think you're going to have a lot of questions on it. I remembered a couple things, and it helped me get the few questions I had in school and the few questions that I saw. So these are the only things that I remember, and I think this will be enough for you. So first of all, you need to know the normal numbers. So normal pH is anywhere from 7.35 to 7.45. Your carbon dioxide, your PCO2 is going to be 35 to 45. I made those in red because it makes it easy, because the pH ends in 3,5 and 4,5, and so does the PCO2. So I think that helps. Your bicarb is 22 to 26. And again, these numbers are important to know, but I would also remember the middle of these numbers, because sometimes you're going to have a patient that has a pH of maybe 7.36, so it's not necessarily acidotic, and you may say, well, it's not, because they normally want you to know like less than 7.35 or more than 7.45, decide if it's acidosis or alkalosis, but sometimes they'll be somewhere in between. So also know the middle of the numbers, and I'll go into that more later, but So 7.35 to 7.45. Remember, the middle of that is 7.4, 35 to 45 is 40, and 22 to 26 is 24. And it's nice because they all have the number 4 in them. So then also remember Rome, and this I got from Pants Pearls, and I never forget it, and it's always helped me in the questions. So Rome stands for respiratory opposite, metabolic exact, and I'm going to go over that in a minute. So that makes sense. So the first thing you want to decide is the patient in acidosis or are they in alkalosis. So you look at the pH, and if the pH is over 7.45, it's alkalosis. If it's 7.35, it's acidosis. And again, you may have somewhere in between, so that's why it's important to remember that 7.4 number, because if you have a patient that's like 7.37, well, you know 7.4 is the midline, so 7.37 is more acidotic. And I remember learning this and not really thinking about that. And then I had a question like that in school, and I was kind of confused for a second because I'm like, well, it's not less than 7.35. So just remember 7.4, the middle, and then you know if it's less or higher, then you can decide whether it's acidosis or alkalosis. I hope that's not confusing, but I just wanted to make a point of that because I remember that confused me. So next, you're going to look is the carbon dioxide elevated or is it decreased? So is it less than 35 or is it more than 45? And again, remember that 40 because it may be somewhere in between. So if it's elevated and the pH is decreased, so say you have a patient with a PCO2 of 47, so that's elevated, and they have a pH of 7.25. So the pH is decreased because it's less than 7.35, and the PCO2 is elevated. So they're opposite. So if you remember Rome, you remember respiratory opposite. So that actually means we have a primary respiratory disorder. So again, the first two letters in Rome, respiratory opposite. So if the PCO2 is opposite, if it's going in an opposite direction, if it's decreased, and the pH is increased, or the other way around, if the PCO2 is elevated and the PCO2, I don't know if that's what I just said, but anyways, if they're opposite, then you're going to have a primary respiratory disorder. If they're going in the same direction, the PCO2 is elevated and the pH is elevated, then it's not a primary respiratory disorder. So now you're going to do the same thing with a bicarb. Look at the bicarb, which should normally be 22 to 26. So if it's elevated and the pH is elevated, think of Rome. ME stands for metabolic exact or metabolic. That's how I remembered it. So it's going in the exact direction. Um, so so say the bicarb is 27, that's elevated, and the pH was 7.47, that's elevated. So exact direction, that means it's a primary metabolic disorder. So let's the other thing I would say, I don't recommend learning the Antiion Gap formula. I feel like I took the time to learn it, and I don't remember ever really seeing any questions on it, or maybe a question or two, but I don't think it's that important. And there's too many other things to learn that I would just remember these few things, and I think that's enough for the few questions that you may get, or one question. So let's go through an example. All right, so you have a patient with a pH of 7.29. Their PCO2 is 30, and their bicarb is 21. So the first thing is this acidosis or alkalosis. So if you remember, 7.35 to 7.45 is the normal range. 7.29 is less than 7.35, so the lower end. So that means this patient is in acidosis. So the next thing that you want to look at after that, so acidosis less than 7.35. So next, let's first look at the PCO2. Are the PCO2 and pH going in opposite directions to indicate a primary respiratory acidosis? So let's see. So the pH is decreased, so it's down, and the PCO2 normally is 35 to 45. So are they going in opposite directions or are they going in the same direction? They're going in the same direction because PCO2 is 35 to 45, so it's decreased. pH, same thing, 7.35 to 7.45, it's decreased. And if we remember Rome, respiratory opposite, they're not opposite, they're in the same direction, so we know it can't be a primary respiratory because the pH is decreased and the PCO2 is decreased. So now we know that it must be metabolic. So let's look at the bicarb and the pH. So the bicarb, which is normally 22 to 26, that's decreased. The pH is also decreased. So we go back to Rome, metabolic exact. They're going in the exact same direction. So we know this is a primary metabolic acidosis. So yes, pH is decreased, bicarb is decreased, so this is a primary metabolic acidosis. And then a final thing to note, you should also look to see if there's any compensation going on. So the way you decide if there's compensation, so first figure out what your primary disorder is. So we know this is a primary metabolic acidosis. So if you have a primary metabolic acidosis, normally happening in the kidneys, are the lungs compensating for this? Are they trying to compensate for the acidosis that's going on in the body by having an opposite alkalosis? So the way you decide that is the PCO2 out of range, and is it out of range? Is it decreased, which would indicate more alkalotic state? And it is in this case. So the PCO2 is actually decreased down to 30. So we know we have some kind of compensation going on. So if this was in the range of 35 to 45, we know that there hasn't been any compensation because it's normal, but it's not. It's actually decreased. So it's trying to compensate for the metabolic acidosis. And the way you decide whether it's a full or partial compensation is you look at the pH. Is the pH normal? If it's normal, then it's a full compensation. If it's out of the range, it's only a partial compensation. So in this case, we have a primary metabolic acidosis with a partial respiratory compensation. And I'm sorry if that's a little confusing. I'm trying my best to explain this in a way that makes sense. So that's what I went over here. Is there any compensation? Decide this by first seeing if the pH is normal, which would indicate a full compensation. It's not. It's out of the normal range, so we know it can only be partial at best. So the pH isn't normal, so it's likely a partial compensation. And we conclude that since the PCO2 is decreased, there's a partial respiratory compensation. So the final answer will be primary metabolic acidosis with partial respiratory compensation. All right, so let's go on to hyperkalemia. A little bit easier, more straightforward than that was. So hyperkalemia is a patient that has a potassium over 5. So the way I remember the causes of hyperkalemia is by remembering the mnemonic CARED. So each letter of CARED stands for a different cause of hyperkalemia. So the first thing that you want to think of when you think of hyperkalemia is cellular lysis. So this is anything that's going to damage the cell and pour potassium from the intracellular space into the extracellular. So think of rhabdo, think of burns, think of tumor lysis syndrome. Anything you can think of that damages the cell, makes the cell lyse and pour all of its contents into the extracellular space. So it doesn't have to be anything, too difficult here, just a damage to the cell that's pouring all this excess potassium into the extracellular space. And some of the more common ones are rhabdo, burns, tumor lysis syndrome. So that's the first letter in CARED. Next is aldosterone decrease. So anything that causes an aldosterone decrease, hyperaldosteronism, adrenal insufficiency, pretty straightforward. Next one is renal failure. This is probably the biggest one, the most common cause of, besides ACEs and ARBs and things like that, of hyperkalemia. So really remember this one. This is a huge one. The kidneys are no longer able to flush out all the excess potassium, and you're going to see patients with renal failure with hyperkalemia, which kind of goes into the next one because excess potassium intake. You're not going to see a normal person eating 5 bananas and having hyperkalemia. It's just not going to happen. Your body's able to process it. Your kidneys are able to get rid of the excess. But the patients you will see this in is a patient that's on dialysis, patient that's in kidney failure and renal failure. They have the potential to go, to have hyperkalemia from an excess potassium intake. So they may eat 3 or 4 bananas and actually have hyperkalemia. So excessive potassium intake in a patient who's susceptible, like a patient on dialysis. And then the last letter in CARED would be drugs, and this is another big one, ACEs and ARBs. I see this all the time in my patients taking lisinopril, losartan, catepril, whatever it is. You'll see a mild, you're not going to see over 6, but you're going to see maybe like a 5.2, 5.3 from a patient who's on lisinopril or another ACE or ARB, or or a potassium sparing diuretic like spironolactone. That's pretty common. So again, you may see a mild increase in the potassium in these types of patients. So the two that I would remember, if I'm going to remember anything from these, you can remember the mnemonic cared and you can kind of get all of them, but certainly remember renal failure and then remember your ACEs and ARBs because those are some pretty common ones, especially I feel like in the vignettes that you'll see. So as far as the presentation, the big one here is cardiac arrhythmias, and that's what we want to prevent when we have a patient who has hyperkalemia. We also may see some muscle weakness, flaccid paralysis, abdominal distension, and diarrhea, but the big one is cardiac arrhythmia. So on EKG, I think this is, if you forget everything you learned in EKG and PA school, I think you'll never forget the tall peak T waves because that's just one of those things that's drilled into your head over and over and over. Tall peak T waves on EKG, hyperkalemia. It can also lead to QR interval shortening, a wide QRS, but the main thing on EKG and the thing you'll probably see is tall peak T waves. That's huge. This is a look at what an EKG will look like with tall peak T waves. You can see these huge T waves here. It's not always this dramatic, but if you see this global T wave, global peak T waves, on the entire EKG, always your mind should go right to hyperkalemia. So that's a good example here. Again, it's not always going to be that dramatic, but that's something you need to remember, tall PT waves on EKG. So as far as the treatment, the way I remember this is C big K drop. So C big K drop, like seeing your potassium drop. This is a very easy way to remember this. So let's go through the letters. First thing, calcium gluconate. So does calcium gluconate do anything to decrease the potassium in the body? No. What you give calcium gluconate for, and the reason you give it before anything else, especially when you're seeing a patient in the emergency room, is because you're preventing the arrhythmias that hyperkalemia causes. So it actually increases the threshold potential of the cardiac myocytes, which prevents arrhythmias. And this is the first thing you're giving to somebody with hyperkalemia in the ER. And if you're in an outpatient setting and you have a patient that has like a 5.4 potassium, no. But in the ER, calcium gluconate is the first thing, and that's your C from C big K drop. Next thing is beta 2 agonist or bicarb. Bicarb is not used very often. It's still kind of listed on the treatment options, and you may see it in a question, so it's good to know it. But beta 2 agonist is more commonly used. So albuterol, those types of things are also used to help push the potassium into the cells and out of the extracellular space. So that's the B and C big K drop. Next one is insulin. And insulin is another thing that helps push the potassium from the extracellular into the intracellular space. And then, of course, the next thing that comes in the C big K drop, and only because we're giving insulin, is glucose. And you don't want the patient to go low giving them all this insulin, so you have to give them dextrose or glucose. Next thing is another one that we don't use very often, and it's mainly because it's so slow. It can take days for K-exolate to actually decrease the potassium in the body. So you're not going to see this used in an ER. You may see it used in an outpatient setting, maybe if you have somebody who's a little bit elevated and you're not in any rush to bring it down, but it's not something that's commonly used anymore. But that is another thing that was at one time used and you may see possibly in a vignette. And then finally, in a refractory patient that nothing else is working, you can do hemodialysis to pull out all the excess potassium, especially in a patient who's in renal failure and their kidneys aren't, doing the job for their body. So that's the mnemonic to remember. This is how I remembered it. I'll never forget this. And I think you should commit this one to memory because it's an easy way to remember the treatment for hyperkalemia, which is important. So C big K drop. And then the last thing is hypokalemia. Just a note, there's a couple other electrolyte abnormalities that I'm not going to go into because I don't think they're that important. If you want to review them, like hypomagnesemia and hypermagnesemia, they're pretty straightforward. They're not very high yield. I'm going over the things that I feel like is important that you may see on exams. So if you want to, I would definitely recommend reviewing those, but I'm not going to go over those today, but I just wanted to make note because that is in the blueprint. So hypokalemia, one of the main causes is going to be a GI loss, whether it's diarrhea, vomiting, diuretics, like your thiazides and your loop diuretics can all cause hypokalemia. So medications that can cause intracellular potassium shift. So these are basically all the things that we just went over that treat hyperkalemia can cause hypokalemia, and that of course makes 100%, it makes sense. So your beta 2 agonist, your insulin, anything that you treat hyperkalemia with can, ultimately cause hypokalemia. So that's another one to know. And then hypomagnesemia. This one's important. So in a patient who has hypomagnesemia, the low magnesium actually opens magnesium-dependent potassium channels, and this spills the intracellular potassium out into the urine, and actually flushes it out of the body. So you can actually have hypokalemia. And why this one is so important is because if you're treating a patient with hypokalemia and you're giving them potassium and their potassium is not getting any better, you're not seeing any changes, you need to consider that they also may have hypomagnesemia. And if you don't treat the hypomagnesemia, nothing's going to happen with the potassium. You're never going to be able to correct the potassium until you correct the magnesium. So that's important to remember in real life, when you're actually treating patients, and also in some questions and vignettes, because it may say that you've been treating this patient who has hypokalemia with potassium, you're seeing no change in their potassium levels. What should you consider next, or how, what should you treat to correct this? And the correct answer would be to treat the decreased magnesium, the hypomagnesemia. So that's important to know. So as far as the presentation, they may have severe muscle weakness. This is more pronounced than with hyperkalemia. You're also going to have decreased deep tendon reflexes, and also palpitations and arrhythmias may be seen as well. EKG, this is another big one. Not as big as the peak T waves, but the U waves are another big one that I don't, that I won't soon forget, and that I certainly remember learning about. So you'll see some T wave flattening, and then after the T wave, you're actually going to see this second little hump there, and that's your U wave. And that's something that you'll see on EKG, and that's something that if they're going to give you an EKG with a patient with hypokalemia, I'm pretty sure you're going to see a U wave there. So that's a pretty big one for hypokalemia, and I certainly remember that from school. And this is an EKG showing that U wave. So you see your big T wave there, and then right after you see just an extra little hump before your P wave, and that's a U wave. So if you ever see something extra after the T wave, consider that, consider hypokalemia. Again, EKG is not the way you're going to be diagnosing hypokalemia, but if you have a patient maybe at an urgent care or something like that, you do an EKG, you don't have an on-site lab, and you see this on the EKG, it's good to consider that they may be potassium deficient, but definitely remember this U wave here. That's important. As far as treatment, so oral is actually the mainstay of treatment. IV, you're only going to use in severe cases. So that is the last section for the renal review for the PANCE and for your exams and your EORs. I just want to thank you guys for watching, and I want to let you know that I'm gonna, more consistently be putting out new videos. I just started this, so just subscribe, like my videos. I'm coming out with more stuff. I also just started an Instagram page too, where I'm putting out more of my mnemonics and different things on there. If you want to subscribe, it's under the same name, Cram the Pants on Instagram. So subscribe. I'll be coming out with new videos, probably trying to get out like a couple a week now. And thank you for watching.